Hi everyone, welcome to LUCC, Learning Ultrasound in Critically Ill. LUCC is a tremendously exciting initiative by a bunch of interested individuals. We all want to teach point of care or bedside ultrasound in the ICU for critical care trainees. We want to equip you with the basics of diagnostic ultrasonography in various conditions. We believe that ultrasound is going to revolutionize diagnostic management, diagnostic processes in the ICU, and the next generation of ICU trainees must have the basic expertise. We believe that ultrasound can be taught and learned in a standardized manner, and we believe that it can be made fun. So welcome. My name is Arvind Rajamani, and I work at the Nepean Hospital in Sydney in Australia. And I am coordinating this initiative along with a large number of interested individuals who are very keen and devoted to teaching ultrasound. In this presentation, what I'll be covering will be an introduction to the course itself, so the Learning Ultrasound in Critical Care course, an online and a physics module, and then biliary and renal tract ultrasound, lung ultrasound, and above limb DVT. Depending on what you've signed up for, you may or may not have access to each of these modalities. So that's something that we'll have to negotiate with the local supervisor and with myself. What is this program about? LUCC has been conceived to answer a very important question for policymakers, which is to determine the learning curve for point-of-care ultrasound in the ICU. Now, although everyone accepts that point-of-care ultrasound is hugely important and that ultrasound can be reliably done by trainees and by ICU clinicians to answer some specific questions related to critically ill patients, there is actually not much data about how to do the training, and how many studies people have to do before they reach competency. And in fact, there's not much data at all about how to ascertain whether a particular trainee has become competent. When do we say that you're able to make clinical decisions based on your ultrasound? Therefore, this is going to be very, very hugely important for policymakers when writing training curricula, and we hope to fill an important gap in the policy sphere. What is your role in this? You undergo the training, and after today's training, you will start doing ultrasound studies 10 at a time. You will have to do about 30 studies in all, but sometimes perhaps more than 30 studies, but at least 30 studies. But you'll do them 10 at a time, and each time you do a scan, you will fill a logbook. You will have to save these studies. Then you'll have to either contact myself or your local supervisor for feedback, go back and do another 10 studies and do that same process and another 10 studies and then come back for feedback. You have to do each of these things, the entire 30 studies, within 3 months, and after that you will be asked to sit an MCQ test and an image interpretation test. You'll realize that this is going to be a fair amount of work in 3 months. If you do not think that you have the time commitment or the motivation to be able to complete all of these things within 3 months, please do not enroll for this. I have been disappointed by a number of trainees who have taken this on but have then not completed their 30 scans. This is something that we want to avoid. So I repeat, if you do not believe that you have the time or the energy or the commitment to go on with this, this is the time to drop out. If you want to proceed, then this is the website for initial registration, okay? And then the modality that you are going to undergo training you have to register that as well. So these two are the registration links, and you'll get this in an email as well. Once you've got this initial training, starting from tomorrow, within the next 15 days, do 10 scans and keep going to your local supervisor for feedback. Now we'll see how you have to start performing the scans themselves. First of all, how do you choose a patient for a scan? Now, because of various regulations, we are compelling people to choose patients who have clinical indications for the scan, which is, therefore, you can't just take healthy volunteers. You just can't go ask 30 of your friends to come up one day and finish 30 scans. Each of the patients that you're choosing for scan must have a clinical indication for that modality. And the definition of clinical indication, the usual rule of thumb is, if it's really clinically indicated, you are going to get some form of formal imaging as well. As an example, if you're going to do a lung ultrasound on someone, it means that you should get a chest X-ray or a CT scan, one of these two. Okay? If you get a gallbladder, if you want to do a gallbladder ultrasound, it means that you must be worried enough to get a formal gallbladder ultrasound by the radiology department. Same thing for a DVT scan or a renal tract scan or anything. If you do not believe that there is a clinical indication to trouble the radiology department or the chest X-ray, then it means that these patients do not have a valid clinical indication and they should not be chosen. Okay? And just as a corollary, an important thing, once you've got the formal test, please document the results of this formal imaging test in your logbook, and you may have to do this 3 or 4 days later because the gallbladder scan may not happen for the next 3 or 4 days. So please do that. A number of people ask me, can many trainees scan the same patient? The answer is yes. This is not cheating. So if your friend has told you that a patient has a fantastic gallstone or signs of cholecystitis, now it's still your job, even though he's told you this, it's still your job to actually get the images to prove this. So I don't believe that this is cheating. Obviously, if you do not know the diagnosis and walk in there blind, that's better. Now, can you scan the same patient again and again and again? The answer is yes and no. If the clinical indication has not changed at all, then that's cheating. Do not scan him more than once. But if there is a new clinical indication for that modality, so for example, you've scanned somebody on day 1 with community-acquired pneumonia. On day 2, you're not going to scan him again unless things have changed. But on day 10, if you suspect a new hospital-acquired pneumonia, you can scan him again. Or you're suspecting pleural effusion, you can scan him again. Or you've messed up with the subclavian central line and you want to rule out a pneumothorax, that's a different clinical indication and you can scan him again. So the answer is no problems if the clinical indication has changed. Saving a study has a defined format. The most important thing is that this must be de-identified. Okay, so you should not, the de-identification is crucial. You should not have any patient identifying data. And for that, there is a defined way of entering this. You enter the last 5 digits of your mobile number, followed by the last 3 digits of the patient's MRN, and then followed by the number of scans you've done on that patient. So if you've done a cardiac ultrasound and a gallbladder ultrasound in that patient, and now you're doing a lung ultrasound, it'll be scan number 3. Okay, the gallbladder ultrasound will be scan number 2, and the cardiac ultrasound will be scan number 1. And this is how you should name this in the patient's last name on the machine. This will also go, exactly this thing will go on the reporting form. Saving the study, save it in the lowest form possible size, which gives you a good resolution. So you'll have to play with your machine to see how you can save it. Some machines offer a DICOM format which you can save it in. Some machines save it in a video clip or a JPEG image, which is called a PC format. You'll have to play with it and ask your local supervisor to help you with this. Now, again, do you need video or still images? There are some studies which absolutely need video images. For example, you can't have a cardiac echo or a lung ultrasound with a still image. Okay, I don't want to have a pretty picture of the heart. I want a pretty video of the heart. For all the others, usually I think frozen images are better. So if you think that dynamic movements are required, dynamic, for some color, if you're putting color Doppler or something like that, then you can get a video. But in the majority of all the other things, you can just get still images. And the advantage of having still images is that the size of the file is much smaller than a video clip. What is the minimum number of acceptable images for each study? I will give you a cheat sheet which you can take and you can use this to say, okay, these are the images that I have to get. You'll also find that the reporting forms not only are a good log, but they're also a beautiful reminder for the number of for whatever images that for whatever you have to get. Uploading the study. Now the official website to upload it is a Google Drive website. The username is luckultrasound@gmail.com and the password is ultrasound. There is a folder called trainee ultrasounds to be uploaded. If you go into this folder, you will then find subfolders under your hospital, and then under the subfolder you'll have some modalities, so DVT for example, and your name, and that's where you have to upload each patient as a separate folder. So if you have 10 scans, if you've scanned 10 patients the first time around, each patient of yours will have a separate, you'll have to paste them as a separate folder. Okay. Now some people have told me that it takes a very long time to upload it to the Google Drive website. I'm happy for you to do it in any other cloud storage thing like Dropbox or Microsoft OneDrive and send the link to me and I'll be able to download it. Alternatively, if you find that even that is difficult and you live in Australia, then I'm happy for you to burn DVDs and post it to me. Okay. Now, make an appointment with your local supervisor, but make sure that you go and meet them with 10 studies every 15 days. What do you get out of it? You get a tremendous amount of benefit. First of all, you get mentor training and expertise. And I have to say that I'm not aware of any other ultrasound course where you actually get not just the initial training and hands-on, but also the supervision subsequently. Okay, and this model is I think going to be crucial in making sure that you have a good structured ongoing training for 3 months. Second, if you finish all the course requirements for LUCC, getting the CCPU by the Australasian Society of Ultrasound Medicine is just a very small additional step. It costs another additional fee charged by ASM, but the only additional activities that you need to do to get the CCPU are, after you pay the fee, is to do an online physics module, which should be, I've been told that it's very easy. I've not done it myself, but I believe that it's very easy. The most difficult thing to get the CCPU is actually to do the 30 scans and to get them evaluated by a supervisor, and we are doing that for you as part of LUCC. We are also applying to the CICM for the echo module, but we should not have any difficulties getting the accreditation. In summary, LUCC is a semi-supervised model of point-of-care ultrasound training. It comes with a lot of commitment from you. And if you don't have the time or the energy or the commitment, I reiterate, drop out now. But believe me, if you go through this, you're going to see tremendous benefits because your clinical practice is likely to change quite a lot because of your skills in ultrasound. And it's tremendously exciting to be part of this journey. All the best. We now come to the next section on ultrasound physics. Don't switch off. I know that the word physics is one of the reasons why a lot of us became doctors, physics and maths. But the basics of physics are very, very important in learning how to do diagnostic ultrasonography. There are a number of important concepts without which we cannot truly become good at ultrasonography. And I'll try to make it as simple, and I can't promise to make it fun, but I'll try to at least keep it simple. And the good thing about doing this in front of a computer is you can nod off and sleep, but remember, you still have to go and do the tests later, which means that you might have to listen to this talk all over again if you slept. So keep awake. We'll start off with a wow factor. Okay? And when I say this, you may have encountered this before. You may have thought about this before, or you may never have thought about this before, but this is something mind-boggling. What does ultrasound do? What magic does it do? With ultrasound, you're actually able to see sound. If you think about it, it's just amazing. Okay, you really are able to see a sound wave that has gone in and come out, and the computer is beautifully able to depict that as an image. Now, if that is not wonderful, if that is not an achievement of science, nothing is. So we'll try to understand over the next few slides how the ultrasound machine is so beautifully and cleverly able to convert sound to something that you can see. In order to generate ultrasound, the principles are, first of all, you need to have a machine that emits sound waves. Next, these sound waves travel through the tissues, and the tissues will start interacting with the ultrasound beam. So some get reflected back to the probe, and that's why these are called echoes. So just like how you shout in a valley and you hear echoes coming back, some of these sound waves that are emitted by the ultrasound probe get reflected back to the probe, and these are called echoes. Now these echoes are the ones that are seen on the image as an image on the screen, and therefore they're called echogenic. Now some of these sound waves do not come back as echoes, they just pass through completely, and therefore in those areas where the ultrasound beam does not come back and does not produce echoes, it becomes black, and that's called anechoic. Now once again we'll go back to how the image is constructed on the screen, because it's just beautiful. First of all, step one, you need to have the ultrasound beam generated by the transducer. Second, this beam enters the tissue. Third, the beam starts interacting with the tissue, and the interaction could be, as I said before, reflection or passing through, and there are a few other forms of interaction like scattering and refraction and so on, but at this stage we'll keep it simple. Some of the ultrasound beam can get reflected back as an echo, or some of it just passes through and does not produce an echo. Now the computer processes this information. It processes the returning echoes, and it does two types of processing. One is it looks at the strength of the echo, and from the strength of the echo it gets the brightness. And the second is it takes the time delay from the emission of the beam, so from here, from the generation of the ultrasound beam, to the returning echo. So the time taken from step 1 to step 3, to step 1 to step 4. And based on this, it's able to give you a depth perception. So it is able to tell you that some of the echoes have been generated from a structure that's about 1 centimeter from the probe, and some of the echoes are coming from a structure that's about 10 centimeters from the probe. So let's see how the ultrasound probe is able to generate ultrasound waves or ultrasound beam. This is by a beautiful effect called the piezoelectric effect, and this was first demonstrated by the Curie brothers, 150 years ago. My maths is wrong, as you can see. Okay. And essentially what this is that you have electrical energy going and agitating a substance, a crystal, and this crystal starts vibrating, and that vibration results in a production of sound energy. So essentially what we have is conversion of electrical energy to sound energy. Okay, and this sound is called ultrasound, and the reason why it's called ultrasound is because we cannot hear it with the human ear. Okay, it's beyond the frequency of hearing by the human ear, but it's essentially sound. Okay, it's just a different type of sound, and it's produced by this effect called the piezoelectric effect. Now, the ultrasound transducer has a number of piezoelectric crystals packed inside. So this is how an ultrasound transducer will look like if you cut it open. Now, these blue things here, these are actually many crystals, okay, all packed tightly side to side. And what happens is the power cable of that runs along the cord of the ultrasound transducer, sorry, goes and hits and produces an electric current that goes and hits these piezoelectric elements of the crystal. Now these crystals will now start vibrating, and when it vibrates, it then produces a sound energy that comes from the head of the crystal. Now the next step is what happens to the beam inside the body. So it starts interacting with the various tissues, and the interaction depends on the impedance of the tissue. Now impedance is, crudely put, impedance is a form of resistance. Okay, so what it does to the ultrasound beam. So some tissues will reflect the beam, and therefore it will produce a returning echo. So as far as the transducer is concerned, it gets back a sound, and that is called a sound. It's called an echo. Some tissues, on the other hand, will just allow the beam to pass through completely, and therefore it won't have any returning echoes coming from there. Most tissues are in between. They allow some of the beam to go through, and they reflect some of the beam. And in addition to this, as I've already said, some tissues will scatter the beam and some tissues will refract the beam. So this is an example of how a beam is going to be reflected back faithfully. Okay, so the beam goes down, and subsequently it's a flat surface, it's a flat tissue, and this flat tissue will reflect the beam back, okay, like this, in the direction that it came from. On the other hand, look at this tissue. This has a kind of a ragged surface. Okay, so what happens is when the ultrasound beam goes and hits it down, there are only some portions of this surface that actually reflect the ultrasound beam back in the direction it comes from. A number of other things, they just scatter the beam this way and this way and this way and this way, etc. Okay, so this is an example of how tissues scatter the ultrasound beam back, and therefore these structures here, so these echoes from here and these echoes from here will actually not be going back to the probe as returning echoes at all. They will just be interpreted by the probe as black spots. Okay, this is an example of refraction where the ultrasound beam, this is the beam, and this is the tissue here. Okay, there are two media, a medium 1 and a medium 2. These have different tissue impedances. For example, you can think of this as the wall of the gallbladder with cyst inside, so with fluid inside. Okay, so the wall of the gallbladder is medium 1 and the fluid is medium 2. Now the ultrasound beam, when it hits the interface between the two media, will change its angle. So it changes. See how that's the angle of the incident ultrasound beam. This is the angle of the beam that passes through. Okay, and the same thing happens on the way back. The returning echo, so it hits, say it hits a structure here. Okay, it hits a gallstone or something. Now that returning echo will go back, and it once again at this interface between the two media, it can undergo a different refraction. So some of it might go back to the probe, or some of it may get reflected in a different angle. So this is called refraction. Now clinically these things are important in the production of artifacts. Okay, scattering, refraction, and all these things produce artifacts. And this might be a little bit too much beyond your grasp at this time. Okay, so we'll keep it simple, just keep things simple to ultrasound beam can either get reflected back as an echo, or it can be allowed to, it'll pass through without producing any echoes. So the next thing is what happens to the returning echo. Now, as we know, echo is the returning sound. It has energy. And the sound energy goes and hits the transducer it hits the piezoelectric crystal in the transducer, and it agitates the crystal. The crystal starts vibrating again and again, just like how the crystal started vibrating when electric current hit it on the way in. And this produces what is called the piezoelectric effect, and this results in conversion of the sound energy, so the conversion of the sound energy to electrical energy. Now, a computer does something very clever. It converts this electrical energy to a visible image. The brightness of the image depends on the strength of the electrical voltage that is generated. And the strength of the electrical voltage that is generated in turn depends on the strength of the returning echo. So the stronger the returning echo, the higher will be the electrical voltage, and the higher will be the brighter the image. So I repeat, the stronger the returning echo, the greater will be, or the higher the electrical voltage, and therefore the image will be brighter. So if you just take two steps, if you have a strong echo, it will result in a bright image. Okay? And the corollary is on the other side, on the flip side, if you have a weak echo, you will have a dark image. Okay? And if you have no echo coming back, you will have a black image. So let's see how this interacts in real time in a patient. So this is a crude drawing of the liver, and this patient's liver has a simple hepatic cyst. This cyst has a lot of fluid inside. Now the ultrasound beam is coming in from the transducer, and it hits the anterior surface of the liver, and it goes back, and the anterior surface of the liver is beautifully depicted on the screen. So this is how the anterior surface of the liver will now be depicted on the screen. Next, you're going to have the beam going in, okay, and some of the beam starts going beyond the anterior surface of the liver, and it goes down to the deeper structure of the liver parenchyma here and here. But look at what happens here. It's going down through the cyst. Now, coming from the liver and the parenchyma, the echoes get generated which go back to the probe. So echoes get generated back to the probe. But through the cyst, there is no echo generated at all from the body of the cyst, and it just keeps going on and on and on. Once it goes beyond and goes to the deeper wall of the cyst, from here you will start having returning echoes. Okay? So that's how it works. And from the deeper structures and from the posterior surface of the liver, you will then have returning echoes. But from the actual cyst, you will not have any echoes going back. Once again now, what do you see on the screen? You see sound, and you see those ultrasound beams that return to the transducer, and they are echogenic. If a structure does not reflect the ultrasound beam and it allows it to pass through completely, it becomes anechogenic or anechoic. And all this is, by now it should be a revision for you. The denser the structure, the more echoes it produces, and therefore this is hyperechoic. Examples for hyperechoic structures are bone, pericardium, and for some reason it's air as well. air has this capability of actually scattering echoes in all directions, and it produces very bright echoes, very dirty kind of echoes, okay? It doesn't have any structure to it, it's just there all over. If you have clear fluid, that clear fluid will allow all the echoes to, also all the ultrasound beam to go through, and therefore there won't be any echoes coming back. This is called anechoic. And in the body, the normal fluid that you can see are gallbladder fluid, urine in the urinary bladder, a simple pleural effusion, blood in blood vessels, okay? But blood in blood vessels will actually have a mixed echogenicity, because unlike gallbladder fluid and urine, which are completely clear because they do not have any solid components at all, blood has some solid components within it, which are the red blood cells and the white blood cells. Therefore, blood will not be completely black. Blood will be a darkish sort of gray. And if you actually have a blood clot, a thrombus, you will have a lighter and lighter, so it becomes a little more bright and more and more bright. And old thrombi, which are now almost calcific, will actually be white. The more dense an anatomical structure, the more echoes it will reflect, and therefore the more echogenic the image will be on the screen. And vice versa. The less dense an anatomical structure, the less echoes it will reflect, and therefore the less bright it will be on the screen. It will be darker on the screen. Now we come to the next part of how an image is constructed on the screen, which is the depth perception. How does the computer know that a particular echo is coming from 1 centimeter and another echo is coming from 1.5 centimeters, another echo is coming from 3.2 centimeters, and so on? This is it's actually beautiful in its simplicity. This depends on the time interval between the emission of the beam from the transducer to the return of the echo back to the transducer. So if you say that the emission is time 0, is 0 seconds, the ultrasound beam goes in and goes and interacts with the tissues and gets reflected back. And when it reaches the transducer again as a returning echo, say it's 4 seconds. Now this time interval depends on the distance between the transducer and the tissue from which the echo came back. Okay? Now, and how does this work? Let's go back. The principle of this is the speed or velocity of travel of ultrasound in soft tissue is relatively constant. It's about 1500 meters per second, which is 1.54 millimeters per microsecond. So what it means is that every microsecond the ultrasound beam will go in or come out 1.54 millimeters, 1.5 millimeters every microsecond. For an echo that returns to the transducer, the total time taken is for a to and fro round trip. So the onward journey from the transducer to the tissue, and then the return journey from the tissue back to the transducer for the echo. And this cumulative thing determines the time it takes for the echo to come back to the probe. So if an echo is returning after 1 microsecond from the time that the beam was initially emitted, it means that the depth of that structure from the transducer is roughly 0.77 millimeters. Okay, I repeat, the ultrasound beam takes about 1 microsecond to travel 1.5 millimeters. Because it's a round trip both onward and return, you'll have to divide the time by 2 to get the distance of the structure from the probe. So if an echo comes back after 1 microsecond, so the echo returns to the transducer after 1 microsecond, it means that that structure was about 0.77 millimeters from the probe. So it goes hits the structure, so that takes about 0.77 millimeters, and then comes back another 0.77 millimeters, and that's 1.54 millimeters, and 1.54 millimeters takes about 1 microsecond. This is how the computer determines the depth. Okay, it just takes into account this fixed relationship of the speed of sound in soft tissue. So the longer the time it takes for a returning echo, the deeper the depth of the structure. For example, echoes from the anterior surface of the liver will return to the transducer quicker than the echoes from the posterior surface of the liver. Okay, and the posterior surface of the liver are quicker than the echoes from the kidney. That's how the computer is able to say, this is the anterior surface of the liver, this is the posterior surface of the liver, and this is the kidney deep to it. Okay, and therefore that's how it depicts it on the screen. Now, the next bit of physics, the next bit of how the image is constructed. One very, very important concept that you have to realize is the ultrasound beam travels in only one thin plane. It slices the body, or it sections the body. It has a finite thickness, so it has a thickness like this. Okay, it is not a big fat beam, it's just this thickness. And what it does is, if you have a big tissue like this and you put in the ultrasound beam through that, it sections or slices it only along that particular slice. You therefore don't know of any abnormality that's here or here, nor do you know of any abnormality on the sides. You only know of anything that's present in that particular slice. Okay, so this is therefore only a 2D slice of the organ. If you want to therefore see the organ in its entirety, you have to therefore scan the organ in various different tissue planes, various different angles, various different locations. So, take the example of a liver. So if you have an ultrasound beam in the transverse direction, so if you have the probe facing laterally or transversely on the ultrasound beam, then you will intersect the liver in this axis. So you'll divide it in two halves. Okay, you'll have it like that. Now, the other thing you might have to do is to intersect it like this. So the moral of the story is you have to scan each structure from at least two perpendicular angles, longitudinal transverse, but remember you can also scan it obliquely. So any number of oblique angles is possible, and have fun chasing a structure.